Hello, everyone, and welcome to our session today. Bonjour à tous et à toutes. Happy National Health Ethics Week to all of you. I hope you've had a good week in your organizations. My name is Victoria Seville Klein. I'm the membership officer of the Canadian Bioethics Society board, and I'm really pleased to welcome you to our session today, which is our second episode this year of our Conversations in Canadian Bioethics series. There are a few ways you can join our conversation today. We are very fortunate to have live simultaneous translation available for this session in both English and French. So to hear everything in one particular language, please select that language from the interpretation icon at the bottom of your screen. If you are talented and can understand in both languages, you can leave that off, and then you will hear everything in the original language in which it is spoken. Closed captioning is available for this session, and we will have a substantial Q&A session at the end of both presentations. So please use the Q&A function at the bottom of your screen to enter any questions that you may have. You may enter your questions in either French or English, and you may do that at any point throughout the conversation. So if a question comes to you during one of the presentations, please feel free to type it in at that time, and then we will be able to address that when we get to the discussion period. Your name will not be mentioned alongside your question, but if you're okay with, but other participants will see your name once it's published after the question has been answered live. If you do not wish other participants to see your name, you can choose to ask your question anonymously. We do welcome your feedback for the session and the series. So if you have any suggestions or topics that you would like us to address in a future episode, please contact us at the Canadian Bioethics Society. This session is being recorded in both English and French, and you will be able to access the recording after the event at the Canadian Bioethics Society website. In case you are new to the CBS, the Canadian Bioethics Society is a cross-Canada network for anyone interested in ethics issues related to human health and the biological sciences. So it's a great opportunity to collaborate with peers, to discuss bioethics issues with other people working on areas of interest that you may have about bioethics in Canada. So we are very pleased that we will be launching a new website in the coming weeks that will make all of these networking opportunities easier. So we do encourage you to keep an eye out at this link at our website in the coming weeks to take advantage of all the new features that it will be able to offer. If you are not yet a member of the CBS, please wait for the launch of that website and then please join us. There are a number of new benefits for members that our website will allow us to facilitate for you. One of these is access to a membership directory. So you will be able to see which other members are working on topics of interest to you and be able to network and connect with them. You'll be able to see who might be able to be a mentor for you if you're a student or someone new to the field of bioethics. There will also be a resource repository, which will allow us to more easily share documents and resources that might be of value to ethicists across Canada. So please do keep an eye out for that and join us if you haven't already. You may also join the CBS as an organization. So if your organization is interested in ethics issues, you can join as an organization. The leader of your organization is then able to join our Leaders Forum, which is an opportunity to network with other leaders of ethics organizations across Canada. It enables you to coordinate projects and initiatives in areas of relevance to your organization and the bioethics community, which is just a wonderful opportunity. It does also then allow you to offer discounted membership fees to all of the individuals within your organization. It's also a wonderful way to allow others within your organization to join and access those benefits as well. So please join us if you haven't already, and we look forward to welcoming you with all the new features of our new website anytime. We do have specific benefits for students, including networking events, mentorship events, and skill building workshops. So we're very pleased to announce the launch of a new professional development series for students coming up this year. There are two sessions already scheduled. These are open to all students from undergraduate to postdoc level. You do not need to be a member of the CBS to join, so we encourage you to register. The links for these will also be put in the chat. The first topic is coming up at the end of November, which is teaching you how to write a well-structured paper in bioethics. And it includes from the beginning of how to sort of structure and formulate arguments all the way to navigating the publication process. So if you're interested in writing in bioethics or publishing and developing your skills in the field, we encourage you to come to that event. The second workshop will be coming up in January, which will be discussing core and emerging issues in bioethics. So we welcome all students to attend that. To further the goals of truth and reconciliation, I would like to acknowledge that I am joining you today from the territorial lands of the Indigenous peoples of Treaty 6 and 7 of Alberta and Métis Nation of Alberta Region 3. I encourage all of you to take a moment to acknowledge the land that you're on and the Indigenous peoples, including the Métis, the Inuit, and other ancestors who have lived on and honored this land for centuries. By recognizing this history, we shine light on how our country was settled, and in the spirit of reconciliation, commit to addressing the injustices of the past and the systemic racism and oppression that continue against the Indigenous First Peoples of what is now called North America. I would now like to turn the spotlight over to an organization that we would like to give you the opportunity to learn more about. So I would like to introduce Geneviève Desgagnés, who is going to tell us about le regroupement des éthiciens du réseau de santé et services sociaux du Québec. So merci, Geneviève.
Merci beaucoup. Bonjour à tous.
Thank you very much, and hello, everyone. It's a great pleasure to present our Committee of Ethicists of Quebec's Health and Social Services Network, of which I'm a member, together with Meredith, who is with us today. So who are we? The committee was born at the time of the pandemic. There were about 20 ethics advisors who thought that they should help each other in that period, the very difficult period that we had to go through. And over the years, we thought that we could actually help each other beyond the directives that we got from our ministry during the pandemic. And we thought that we could learn a lot from each other. And it's certainly the same thing in your health institutions. There are very few ethics advisors. So coming together can help with our collective efforts and improve our individual efforts. So we want to have a network to share our knowledge and improve our knowledge. And that's why we created this committee, a kind of structured committee. We needed a structure. And the committee includes all the ethics advisors in the medical field. We have 3 meetings a month. And the 4th meeting is from the organizing committee with 3 or 4 people. We now have 50 members in total, compared to the 20 during the pandemic, and they take part in regularly in the meetings, which shows that there is an interest and there is an added value to this committee. And together we can go further in exchanging knowledge. And the committee also produced some research in the subcommittees, individual projects or done within subgroups. For example, the clinical and organizational ethics organizations, so that we could have an assessment and a list of the existing services in terms of ethics in Quebec. There was also a research project on creativity in ethics. How can we use creativity in organizational ethics and medical consultations? And we also submitted another research project on the identification of the needs in clinical and organizational ethics and everything that has to do with medical aid in dying. So we have really exciting projects, and we've also completed the third ethicists symposium that took place yesterday in Montreal. Every year we have a meeting, a symposium, in order to stimulate reflection and also networking between the different institutions so that we have better cooperation. So that's where we are. We hope that the committee will continue to advance and to grow with more members and have a specific relationship with the Ministry of Health and Social Services in Quebec. You know perhaps that the Quebec Ministry is now delegating some work to Santé Québec, Health Québec, so we'll all be employed by the same employer, which will be called Santé Québec. This is a transition. We have to learn new things, and we hope that the committee will remain robust and solid, and we want to develop links and relationships with you all, because the more people there are, the more we can encourage the use of ethics and discussion on ethics in our institutions. I'm open to questions. You can ask your questions in English if you want, but I will answer them in French.
Merci beaucoup, Geneviève.
Thank you very much, Geneviève. We really appreciate hearing what's happening with other organizations in Canada that work on ethics issues. Thank you.
It's wonderful to hear about other organizations in Canada working on bioethics issues and how you're organized and what issues you focus on. So thank you so much for being with us today and sharing with us about your organization.
Ça fait plaisir.
That was my pleasure.
Okay, so on that note, we will turn it over to our speakers for today. So welcome everyone again to our session today on public health, precarity, and practicing the future. I'm very pleased to have some wonderful speakers with us today. Amy Harbin is an associate professor of philosophy and women and gender studies at Oakland University and is the author of Fearing Together, Ethics for Insecurity, and Disorientation and Moral Life. Michael Doan is an associate professor of philosophy at Oakland University. His research is primarily in social epistemology, social and political philosophy, and moral psychology. Our moderator for the session today is Meredith Schwartz, who is the interim executive clinical and organizational ethicist for Montreal's West Island. She is the author of Moral Respect, Objectification and Healthcare, and editor of the Ethics of Pandemics. So I will turn it over to Meredith to start us off for our discussion.
Thank you very much, Victoria and Geneviève, for your interesting discussions. And thank you, Michael and Amy, for agreeing to be here. So if I could give just a way too brief overview of your perspective, I would say that your paper looks at the question of who is responsible for assuring the public's health or public health. But it does this in a nuanced way by saying that the answer to this question depends on the way we understand individuals and their communities, or how individuals are situated within our communities. So I was hoping that you could begin by telling us a little bit about your perspective about how you understand public health and its differences from clinical medicine, and how you understand precarity and the state's role in producing precarity.
Sure. Thank you so much. I'll say on behalf of both of us, thank you for having us. We're so pleased to be here. We are now situated in the US context. So we both live in Michigan near Detroit. We both grew up in Canada and did our graduate studies in Canada. And so we have a perspective of, a sort of cross-national perspective in a way, which certainly informs the work that we're doing here. But so to your question of public health, I think that, as people who teach bioethics and ethics and work in these areas, we're familiar with a kind of standard, way of differentiating clinical medicine from public health, where clinical medicine is interested in the acute or chronic or preventive healthcare for individuals, and public health is much more interested in health and well-being on a population or community level. That said, in doing this work, probably unsurprisingly to everyone here, those lines really do get blurred. So in the case studies that we talk about and in the context that we're most interested in, we see what would be clinical medicine, right? So issues of care for cancer, care for diabetes, care for reproductive health, care for pregnancies, these sorts of care for asthma, these sorts of issues, really blurred with public health concerns for the health and well-being of broader communities. And so the organizations that we're interested in looking at in this piece, and that we'll talk more about today, are committed to a much more expansive sense of public health and of clinical health, where these things are deeply and inextricably connected, right? They can't be pulled apart. So we can't really understand how to meet the needs of, treatment for sickle cell anemia, apart from understanding state-sanctioned racism in communities in the US, for example. And so one of the groups we talk about, the Panthers, endorsed WHO 1948 definition of health, according to which health is a state of complete physical, mental, and social well-being. And they certainly understood this to be completely bound up with the physical, mental, and social well-being of communities.
Michael, did you want to add anything?
No, I think that's really helpful, Amy, and that I guess the only thing I just want to emphasize is that the folks who were thinking of the groups that we're thinking of, the Black Panther Party and the Common Ground Collective, which sprung up in New Orleans in the wake of Hurricane Katrina, like Amy was saying, both endorse a very sort of wide conception of public health, of what the scope of public health is. So that it would include everything from poverty to sanitation to, some certain aspects of clinical medicine, but also things like, climate change, disaster response, all of which have tremendous implications for the health of communities and populations. And one of the reasons we think that's important is that we've noticed when bioethicists are attempting to answer the question of who is or ought to be responsible for public health, that there's often a tendency to kind of focus on one particular aspect of what might fall within the scope of public health. For example, like pandemic planning is understandably like a focus on a lot of bioethicists right now, and just the public in general, right? It's something we've just lived through a major pandemic, and thinking about who's responsible for dealing with, preparing for, and such things is obviously really important. But it's also interesting thing to think about at the same time when we take one sort of area of public health as our main kind of guiding paradigm. How does that shape what kinds of questions we ask and what kind of answers we give to questions about responsibility? Because, for example, if you focus on pandemics, it might seem that the state ought to play a really prominent, maybe even like the major role in public health initiatives. But if we focus on different examples, then things become a little more complicated.
Right. So one of the things that I really appreciate about your work is the way that you resist both either or thinking. So it's not just that the state should be responsible, but that all different kinds of groups at different levels have roles to play. And of course, some of that is the state as well. And as we were speaking there, I was just thinking about the scenes that we saw in Spain last week, or in the last couple of weeks, with the devastating flooding that they had, and you just saw the massive destruction that obviously is going to impede all kinds of things to do with health. Like sometimes people get angry at activists for blocking roadways, but when we see the effects of climate change and having cars piled up so that roads become impassable by ambulances or even, by pedestrians, we can see how things can affect public health in ways that we might not have predicted if we're just looking at one particular agent's role. So you say that using a relational model of ethics, or a relational approach to ethics, allows a different perspective on public health. And I was wondering, just in case our audience doesn't know entirely what relational ethics is, if you could explain a little bit about what relational ethics is and how it helps us understand that shift in looking at who's responsible for public health.
Yeah, sure. Well, I mean, let's just start with the question of who should be responsible for public health. One of the things that Amy and I were trying to look at in our research is what are all of the different ways that bioethicists have responded to that question, right? What are different accounts of who should be responsible for public health, and what kinds of reasoning do they offer to support the idea that certain agents and not others really ought to be in charge, not only of implementing public health campaigns, but also, for enacting public health related legislation, for, setting research priorities, for actually conducting research, right? There's a whole sort of complicated array of responsibilities that are bound up with protecting and promoting public health. And one of the things that we noticed is that most bioethicists tend to answer that question of who should be responsible in a pretty straightforward way, right? It's like someone asked the question, who's responsible for X? And it's understandable that we tend to just sort of look around and be like, okay, well, what are the options? Could it be Meredith? Could it be Amy? Could it be Geneviève, right? And why should we pick one or the other? And so we noticed that the discourse around responsibility for public health tends to take that sort of shape, right? So there are certain folks who say, for example, that the state ought to play a prominent, or maybe even, the major role in protecting and promoting public health. For example, because the state has coercive powers that other agents don't have, right? Which can be important when it comes to, for example, during a pandemic, making sure that that people are abiding by certain PPE measures and using proper PPE and the like, and using law enforcement to enforce some of those measures. But then there are other folks who notice that, well, depending on what sort of public health challenge or problem we're dealing with, the state might not be the only relevant actor, right? And then we can think of lots of examples where nonprofits might play a prominent role, or other community organizations, or just individual citizens, right? Like if we're dealing with questions around like sanitation, and for example, and want to get a public hand washing campaign going, it's pretty obvious that that's not something that a state government could do on its own. Right? Because at the end of the day, people need to be washing their hands, right? There need to be also, physical infrastructure set up that help to facilitate hand washing, right? Like you can't just approach an institution and say, everyone must now wash their hands every day if you haven't set up, hand washing stations in the hallways and things that make that something that's accessible and possible. So at any rate, we've noticed that there are certain bioethicists who adopt what we call a state-centered approach to public health. And they're the folks who say, well, really, it's the state that ought to play the most prominent role, or perhaps the only role, in taking responsibility for all of the tasks bound up with public health. Whereas others adopt a more, what we call a mixed approach. So they say not just the state, but they also point to other agents and agencies at different levels of human organization playing some kind of role in public health. What we noticed is that the state-centered and mixed approaches both share in common this tendency to, first of all, treat agents as sort of sharply bounded and distinct, right? So there's the state over here, and then there's, you know, individual citizens and nonprofit organizations over there. And also to take for granted agents as they're currently constituted, okay? So in other words, they treat agents as sort of fundamentally separate and as kind of immutable, or at least they take them as they are. Whereas one of the things that we focus on, drawing on Sue Sherwin's and other Canadian feminist bioethicists' really excellent work on public health ethics, is the fact that all agents, regardless of who we're talking about, whether it's state agents, individuals, nonprofits, community groups, whatever, all of their options for acting are shaped and constrained by what other agents at different levels of organization are doing or not doing, right? So take the public hand washing campaign example. It's kind of meaningless to tell individual people working in a hospital that they all are responsible for washing their hands if you haven't provided the facilities that make that actually something that they can do in their day-to-day lives. You know, you have to have hand washing stations set up. Well, who sets up the hand washing stations? Well, you know, maybe the hospital administration. Where do they get their funding from? And so you can see really quickly that even for something really simple like a hand washing campaign, there's a whole lot of different agents involved, and what each of them does or doesn't do helps either enable or thwart the efforts of others. So there are these really massive coordination problems. And on top of that, sometimes some of the agents involved aren't as well suited as they might otherwise be to help enact those responsibilities. So we suggest that we need to start, instead of just answering the question, who's responsible for public health, by pointing to any particular agent or multiple agents. Instead, we need to just sort of step back and ask the question of, well, hold on, who all is involved and who would need to do what for whom and in what ways in order to help, right, reach certain specific public health related goals. And then we really have to pay attention to context, right? What's actually going on? Who actually is involved in the circumstances that we're dealing with? And sometimes that might involve state agents and agencies, sometimes not. Sometimes it arguably should involve state agents and agencies, but the state as currently constituted might actually be exacerbating certain health problems instead of, you know, being equipped in such a way that it can effectively deal with them. So that's what our case studies really highlight, is situations where it's not just that states are neglecting to take responsibility for certain aspects of public health, but sometimes are actively contributing to generating public health problems, which creates situations which really complicate this question of, okay, well, who is responsible for helping to achieve certain public health related goals under those circumstances? So that's what a relational perspective helps us to do, is really think through those really tricky circumstances.
Yeah, and that what you were saying about the hand washing and the different levels of agency made me think of an example that a student of mine brought to me during the pandemic. And he was working at Tim Hortons, and they implemented this policy of ensuring that you're washing your hands every 15 to 20 minutes. But they didn't adjust the other expectations of work. So they continue to maintain the same expectations of volume of output from their employees. That meant that the employees actually didn't have time to wash their hands, even though they were also at the same time being told that they were expected to wash their hands. So there's sort of there can be a conflict there, even if the sink is present and the policy is present. If the time isn't present, you can't really follow through with that. And Amy, did you want to add to our understanding of relational ethics and how it opens up the possibilities for agents to change through their relationships with one another?
Well, just briefly to say, I mean, I think that covers it well, but just as Mike said, right, we're building on a whole tradition of thinking in feminist bioethics in Canada. So coming from Sue Sherwin, and then, so if folks are interested and not familiar with the whole relational autonomy literature and the anthologies and the books in that area, that's sort of what we were trying to learn from and thinking about, you know, these complex public health problems. But I think one of the insights really is a kind of longer view with respect to the goals, right? So when we're thinking about goals, and yes, there are relevant public health goals like a hand washing campaign or like, you know, meeting immediate needs in the aftermath of hurricanes or whatever. There's also a longer view in terms of thinking about responsibilities to change ourselves and also to change the other agents around us. And the ways that our possibilities for action are conditioned by those agents around us and what they do and what they are capable of doing. And so it really is, can be a little overwhelming, but to think about, you know, all of these things are in the context of building new relationships, building new ways of relating to each other and to our contexts. And so when you're, I think this is the richness of relational theorizing, is to really take seriously the idea that we can't actually just drag other agents along with us towards the goals that we've already decided are important. Rather, we have to acknowledge how deeply our possibilities for action are conditioned by them and take seriously the awareness that we're all able to change and we all are changing and we all will be changing. And so as we're building towards whatever goals we might think are important, we're also trying to shape the environments within which we'll later be able to act, right? The conditions for our later action.
Okay, that's excellent. And this leads into, I think, my next question rather nicely. And this is also the point at which I would invite our audience to join the conversation. So if you'd like to put your questions in the Q&A, we will incorporate them into our discussion. These can be questions of clarification or comments that you might want to discuss with us. And don't forget that you can discuss in either English or French, and we will include you in the conversation. So you began to talk about, you know, how our actions can change other agents. So we're not just bringing them along with us, but we're actually engaging in sort of mutual co-construction, if you will. And I was hoping you might talk a little bit in a bit more detail about your examples of the Black Panther Party and the Common Ground Collective and how they used prefigurative politics to develop their public health programs. And how does this inform the approaches of these groups?
Sure. So we do talk briefly in the piece about the notion of prefigurative politics. And so for anyone not familiar, this is basically the idea that the way that we work towards a transformed society will partly determine the kind of transformed society we get, or the how of getting to societal transformation will determine what kind of society we end up with in the end. And so the idea is basically the means of approaching transformation prefigure the ends, right? The transformed society itself. And this would be in contrast to the idea that it sort of doesn't matter how you get to a transformed society as long as it's transformed in the end, and you can make it new when you get there, right? So some people might think, you know, we really need a certain kind of revolution and we will do absolutely whatever it takes to get through that. And then we'll build society anew on the other side. And maybe that revolution involves, you know, like a small group of people dictating how things will go. But that's okay. Once we're at the transformed society stage, you know, we can build a better society then. And so prefigurative politics is in contrast to that, basically saying, no, as we are transforming the society, we should already be working with the principles and the processes that we want to see once we get to that transformed society. So the two core examples that we talk about in the piece of the Black Panther Party and the Common Ground Collective are both really great examples of really intense and serious attention to building the society that's wanted during that process of transformation. And so our first example of the Black Panther Party and their many and various kinds of public health campaigns, that includes things like they developed people's free medical clinics, which were run in part by volunteer clinicians, volunteer nurses, volunteer doctors, volunteer staff. So as they were building clinics, at one point there was a requirement that every chapter of the Black Panther Party would have one of these free medical clinics in their run by the chapter. And so not only did you see provision of care in these clinics, so basic preventive services, basic diagnostic services, some tests and some treatments, but you also saw the skilling of people in the community, right? Building up people's skills and capacities for providing healthcare to each other through the running of these clinics, right? Where it was involving members of the community. The Panthers also had even programs like in some centers, a people's free ambulance that was run by the people. They had door-to-door health, testing where people would go door to door and provide testing. And so all of these things, the goal was not just provision of care and better public health, right? Better attention to the needs and the healthcare needs of the community, but also the building of skills and capacities in doing it so that you would end up with a better skilled and more capable community of taking care of their own health of course, in a state context where it was very clear that Black communities could not rely on the healthcare provision of the state. Indeed, they were in many cases pointing out that the state was exacerbating or creating conditions of ill health. For example, through failing to treat sickle cell anemia is something worth developing a lot of research or treatment for. Right. So that's one sort of example that we draw on. That's a kind of example of prefiguration, where they were building a transformed and better society, providing more healthcare, but also raising the capacities of the people in the community to provide that care. And then the other example, as Mike mentioned, that we draw on is that of the Common Ground Collective, which responded in the immediate aftermath of Hurricane Katrina, and in response to the failures of state organizations like FEMA and the Red Cross to providing adequate supplies and services right after Katrina. The Common Ground Collective was present, developed all kinds of really interesting public health kind of campaigns. So started with, street medics and a first aid kind of clinic that developed into a full, actual medical center or medical clinic that outlasted by far the immediate aftermath of the hurricane. They also had distribution centers for food and supplies. They had legal aid and safe shelter for women and others who are experiencing domestic violence. They had massage and acupuncture and mental health care. And then all the way up to they had defenses for people who were threatened with eviction, during a period of time where there was a lot of pressure to seize resources in the city, and to seize land and houses and property. So all of these, they also saw as like, we want a transformed society where people can access healthcare, where we're able to respond in the face of climate emergency, like hurricanes, where we're able to demand police accountability and prevent police violence, where people have what they need and have mental health care and all of these other supports. They want that in the transformed society. And so the means of getting there involved also cultivating capacities for providing it themselves. And so those are the two examples. And we try to show that they are good examples of relational efforts around public health, where they are responding to the agents and the conditions of agency that they are within, and that they're also prefigurative approaches to doing so.
Yeah, so thanks. I mean, I think that makes the idea of prefigurative politics and its importance really clear. But in your discussion, you sort of mentioned, transforming the members of the community and providing them with greater skills and so forth, and also the transformation of society. But does it also transform the state? Like, is the state as an agent transformed by, I don't know, if being part of these activities or resisting these activities? Because we know that, at least in the case of the Panthers, there was some quite serious resistance to their activities by the state.
Mhm.
And so I was just, you talked about a lot of agencies. I was wondering whether it also applies to the state as an agent being transformed through these activities.
Well, just to sort of build on what Amy was saying, I mean, one of the things that we notice that there's a kind of tendency when we look at the activities of the Panthers or Common Ground to say, thank goodness that people stepped up when the state was not fulfilling its responsibilities to various communities, whether it's the Algiers community in New Orleans, or whether it's the east side of Detroit, or what have you. When but we think, like, we see, I think, in what the Panthers and Common Ground were doing, something a little more complex than just picking up where the state failed to act. Partly because their health politics was not only just sort of about filling in where the state left or cast a shadow of neglect, but also about challenging in really thorough and sophisticated ways just about every aspect of the public health programs that were administered by the state. So, for example, folks in the Panthers, before the Black Panther Party was formed in Oakland, a lot of the people who were involved in founding the party had extensive experience working in Lyndon Johnson's anti-poverty programs under the aegis of the War on Poverty. And through that, they had developed a pretty sophisticated analysis of the way that state-driven anti-poverty programs in particular function, the way that they minister to communities in need. And so through that, we see the Panthers developing a critique not only of the state as neglecting communities, but as being incapable of properly attending to and ministering to them. Because when they do, the Panthers' critique was that states seem to be heavily invested in fostering rather than trying to alleviate relationships of dependency, and that really they sort of need to function that way, because otherwise they would bring about their own obsolescence, right? If people became less dependent on state-funded and provided healthcare, the state would become less relevant and would thereby be in some ways disempowered. So when the Panthers designed their survival programs, like Amy was talking about, the People's Free Medical Clinics, those weren't only just like people who are stepping in to do what the state should be doing but wasn't, but rather they were doing things in a fundamentally different way. Everything from, as Amy mentioned before, their definition of health, right? They replaced what they saw as a limited understanding of health that sort of privileged a disease-free baseline, and substituted for that the World Health Organization's definition, which is this more ambitious, right, aspirational kind of understanding of what health is, that talks about complete physical and mental well-being, right? So it's a loftier target that really is more like a conception of human flourishing. And the Panther said, this is what we need to be aiming for, right? That other definition is something that fits very well into right, a capitalist healthcare system that largely functions through the provision of private insurance agencies and the like. So they were challenging the state's definition of health, but also how healthcare was administered to communities. So as Amy was saying, they were really challenging the divide between, for example, givers and receivers of care, or people who are responsible for setting healthcare priorities, and the people who are receiving care. And so by breaking down those sorts of divisions and boundaries between like state bureaucrats and people who are in desperate need of proper health care, they were modeling a different way of working around public health. And they also emphasized the importance of community control over the provision of healthcare in ways that directly challenged what they saw as the sort of, especially the war on poverty's dependency fostering effects. They thought that the state needed to be transformed into something that facilitated the self-determination of communities rather than consistently trying to thwart that, right, and render communities dependent on the largesse of the state. So, and to some extent, obviously, Mayor, as you're saying, by challenging the logic and the way that states operate, they were perceived, for good reason, as a threat, right? J. Edgar Hoover identified the Panthers as, right, the #1 national security threat in the United States in the late 60s. But on the other hand, things that they did by modeling other ways of delivering care and just thinking about what healthcare involves, they also did have some transformative effects on the US state. So for example, the free breakfast and lunch programs that now a lot of us take for granted in public schools in the United States are partly a product of the survival programs that the Panthers were had initiated, right? They had free breakfast for school children programs that were adopted in different ways by state agencies. And of course, they didn't always take the same form, right? They weren't often quite like the Panthers' ways of doing things, but still there were really positive effects that where the way that they were modeling different ways of caring for people did force the state to take some kind of action, in this case by trying to sort of mimic or replace what they were doing by actually offering some services. So yeah.
So that's, I mean, what you're saying is, I think really interesting about the state taking over some of the programs that the Panthers developed. And is that a way of reducing the Panthers' power? Like, is it a strategy? So I'm thinking here a little bit
Sure.
about a paper by Ari Nadler, Gal Harpaz, Gordeski, and Yael Ben David from 2009 called Defensive Helping, where they talk about, I think, sort of what you're alluding to. Your paper reminds me a lot of their work as well, where dependency-oriented help, it sort of reinforces the dependence of certain groups on the group that's giving help. And what Nadler et al. Found is that you can create social psychology experiments where you create in-groups and out-groups, and out-groups, when people perceive them as themselves as helping others, they tend to engage in dependency helping that fosters the reliance on the group providing the help, but gives the group providing the help a sort of heightened sense of how good and magnanimous they are. Whereas when people perceive themselves as helping their own group, they tend to help their own group in ways that, build the kind of skills that you're talking about and increases capacities for autonomy among that group. So I was just wondering if you could talk a little bit more about that. And, it's great if the state is transformed and is taking up the programs that were developed in communities. But also sometimes this seems like the state is doing it for reasons of trying to neuter the power of those groups.
Absolutely. Right. It's a form of co-optation, right? And pacification. Did you want to respond, Amy?
No, you go ahead.
Yeah, and of course, I mean, there are certain. Well, I was thinking of another example, Mayor, one that you brought up when we were talking about this session in advance, the example of decriminalization and criminalization of drug use in public in BC, right? Partly because, and I was thinking of that example partly because, like, there are ways that I think that what the Panthers were doing was a lot of the time positioned as and perceived as kind of criminal by the state, precisely because what it was doing was challenging the underlying logics of what it is to protect and promote public health, how to do that, and so on and so forth. And to that extent, I mean, or in that vein, I think you're absolutely right that, you know, the way that the state was responding was not in a sort of open-minded, like, you know, we're trying to learn from y'all how to do this better kind of thing. It was more like, we're going to take this over or provide a substitute that some people at least won't be able to tell the difference enough, and will sort of, you know, weaken the effectiveness of your campaigns. And that's absolutely true. And I don't think anyone would want to claim that when the state did that, that was some kind of like victory for, right, from the perspective of what the Panthers were ultimately trying to accomplish. On the other hand, does it improve conditions overall in, you know, for a lot of people? Has it improved conditions overall for a lot of people in the United States, you know, for children especially? Like, does it help to have free breakfast and lunch programs at public schools? I mean, of course. Would it be better if there were more of them that were carried out in the spirit of what the Panthers were trying to do? I'd like to say yes, right? But you know, it's not like those ideas and those ways of organizing and, right, continually trying to transform society have disappeared in the wake of that, you know, the co-optation of those programs. I mean, those things endure. And one of the things that we're trying to suggest through this paper is that adopting a relational approach to thinking about public health, you know, helps to sort of bring us all into the frame of that mode of, as Amy was saying, a sort of long range vision of organizing for transformation.
I was just thinking too, to add briefly to that it does seem like, you know, we see and it's different in different state contexts. We certainly see in the US context and in some Canadian contexts that there's a wave of, you know, like sometimes there are more services provided and then they get rolled back and then you get them again and then they get taken away again. And I think part of what the Panthers do in terms of relating to the state, or in terms of shaping how we now relate to the state, is that I think the long view of relationship to the state is, you know, we keep demanding from them what they should be providing. And we also keep making sure that we're not relying on them to provide it, because we can't rely on them to provide it. So there's a kind of like, it's not to say that there's, again, as Mike was saying, that there's no good in providing things like, you know, in having achieved things like a breakfast and lunch for school children program. And that can free up maybe some space and energy to be fighting and demanding for other things. But it's also the skills that have been developed in knowing how to provide those programs when needed and knowing how to feed communities when needed. Those are all there, and we see them when the state, again, like yanks back what it briefly gave. We see them just pop up again. And I think that we have seen this in particular in Detroit, where it's like people have just been, for many decades and hundreds of years, actually, like mistreated and harmed by the state. We see that the deep level of skill in providing for needs in a community-based way, and that those skills get passed and are seen within families and are seen by children, and the children learn them. And it's like, it really is impressive to see how much the demands continue and the state provision of some goods continues, but the belief that that will always be there is not here.
Okay, thanks. I think I'd like to bring in a question from the audience now that I think follows well from what we've been talking about. So the audience member is enjoying the discussion and would love for us to talk more about the responsibility of the state where they are contributing to undesirable or inequitable public health outcomes. They say, I assume you'd argue for some sort of obligation to rectify, mitigate, or repair the effects of failure on the part of the state, but I wonder what you think that might look like in terms of collaborating with communities or individual agents in a deeply relational way. So I think this is a good question because it brings up the idea of precarity that you discuss in your work.
Yeah, so and the question, it seems like, is mostly about, when the state has been an active participant in creating conditions of harm to health, public health harms. The questioner is saying, I assume that you would be holding the state responsible for that and demanding that they rectify the conditions. And I think that's right. I'm thinking of a lot of examples of, queer and trans healthcare, and how many, and I think this was true in my experience in Canada as well, but it's certainly true here, that what we see is a lot of organizations that are led by, organized by queer and trans people who are accessing services, seeing a need for services, seeing a lack of state provision of services. So maybe it's gender affirming healthcare, or maybe it's access to, affordable, affordable care at all, affordable surgery, affordable hormone treatment, whatever it is. And so you see these organizations form, they're led by queer and trans people, and they in many cases have real proficiencies of interacting with state agencies, demanding services from them, insisting on the need for services from them, and sometimes winning services from them. And we see this going all the way back to, even further, but certainly to ACT UP in response to the AIDS crisis and other organizations like that. So yeah, there's demanding and demanding that the state rectify its harms, and that it, for example, have province-wide coverage, and knowing that it will be covered by healthcare, knowing that people can access the clinics they need to get the care they need wherever they live, all of this. But the organizations stay autonomous, and it's really amazing to think about, and I'm sure people here know more about than I do, but it's amazing to see the play of being willing to interact with the state, of insisting that the state do its part, but also insisting that the power remains within the organization itself, and is led by the people who are most familiar with the actual needs of the community. So that's one thing that comes to mind. Just there is demanding, but again, I think it's a much longer view. I think it's much more about, like, what do we need as a community? How are we going to make sure that we get what we need? How is the state one part of that? What skills do we need to make sure that we have and pass on, so that we don't lose sight of the fact that, like, we are empowered to make sure that our own needs are met?
Just to add really briefly, I mean, I think one of the things that Amy and I have been trying to respond to in the literature on the question of who's responsible for, or who should be responsible for public health, is that it strikes me anyway that one reason why someone might be really attracted to what we've called the state-centered approach to responsibility for public health, which is the one that positions the state as the main agent responsible for delivering public health related services, is that sort of approach is likely, I think, to seem most attractive to people in contexts where the state is well resourced, right? Where there's already, for example, a place like Canada where there is universal health care and so on and so forth. But what do we do? Like, that's not a very helpful answer. Saying that the state should be responsible in contexts where it's not well equipped, not well resourced, where there isn't the sort of the same attitude towards the role of government in society. What do we do in those sorts of situations? And I think that it also isn't necessarily, I think, the right move to say that, well, we should be aspiring to the kind of setup that they have in Canada. That what we need rather is an approach to thinking about public health that allows us to deal with many different sorts of contexts and doesn't become irrelevant, when when states become less resource or less capable of delivering the sorts of services that we might expect of them. Because it's, we can keep on saying, well, the state should be doing this, the state, needs to be held responsible, needs to rectify, failures and that sort of thing. But in certain situations, I mean, to be frank, that strikes me as it can be just a really meaningless demand, right? So what do we do in those sorts of situations? And I think that's why, one of the reasons why we've been suggesting that we need approach to thinking about public health that isn't kind of context bound or isn't bound to sort of, situations where states just happen to turn out to be more reliable in meeting the demands that people tend to have around health.
Yeah, thanks. And I think, in addition to the question about whether states are well-resourced or not, there's also the question about whether they're trusted. So I think that's one of the things that we saw
Sure.
quite a lot in the pandemic. I mean, distrust of state was always there, right? It's not like it was a new thing in the pandemic, but I think it got particularly acute during the pandemic. And we can continue to see that now, where people just don't really trust the information that's coming from the state or experts that are perceived as representing the state. And in these kinds of contexts, there might be a lot of use of having more local responses where the local community is seen as more trustworthy than the sort of larger federated community, the state. I want to pick up on something that you mentioned a little bit earlier there, Michael. You were talking about the Canadian context and the example that I had raised, which was, I think, a little bit similar to the work of the Panthers or the Common Ground Collective, and that's the work of the Vancouver Area Network of Drug Users, or VANDU, who advocated for and pioneered safe injection sites and a harm reduction approach to drug use. And as you were saying, there's parallels because in the beginning, this was seen as a criminal activity. Drugs are criminalized. And so having spaces for drug users to supervise each other while they are using drugs is a criminal activity. But then this is another case where after seeing the results, after seeing how many lives were saved by these approaches, many governments became more open to supporting these approaches. And I would say, in this particular context, the way that governments supported these approaches were not as obviously attempting to take the power from the group, right? So they really were providing facilities within public health agencies or within community health centers that were easy to sterilize, that were staffed with nurses and usually some former drug users who were there to talk to people. And it was not done in a way that I think was taking over the activities of VANDU, let's say, but rather supporting them. And there was a lot of reasons to think that these are successful programs. I know I've talked to many drug users who say that in being involved in harm reduction programs was the thing that made them feel respected for the first time in a medical context and really facilitated their access to other kinds of medical care, because previously they'd encountered interactions with healthcare professionals where they felt very stigmatized and disrespected and looked down on. And engaging in these kind of government-supported projects like help them to come to trust the government, other government-provided healthcare services. So I think at first, it wasn't an obvious attempt to try to take the power from groups like Vandu, but nevertheless, as it comes under the purview of government, that means that the government controls it. And I'm not sure if you're aware of this, but the safe injection sites have become controversial. Perhaps less so in BC. Like BC is now talking about recriminalizing drug use, but they're not yet, as far as I know, talking about closing down safe injection sites. In contrast, in Ontario, Doug Ford has decided that he is against safe injection sites and he wants to move to a more abstinence only based approach. So even in that context where governments appear to be supporting the group, once they come under the purview of the government still kind of has a certain type of control. So I was wondering if you could talk about those dynamics a little bit.
Yeah, I mean, I think this is a really fascinating example, Mayor, and thank you for raising it. I mean, my attention when I was reading up about this was immediately directed to this question of whether to criminalize or decriminalize. And as you're saying, I believe it's the NDP government in BC, right? The provincial government is now considering recriminalizing drug use in public spaces. And that's largely in response to, like, as you're saying, complaints that they've been getting about people, for example, in public hospitals who report feeling unsafe in some ways, or whatever it is, uncomfortable. I suppose people might describe it differently in different contexts, but in the presence of people who are injecting, people who are injecting in a public space. And part of the reason that I think that this is such an interesting example is I think that it both shows up the limitations of having a kind of state-focused or state-oriented way of thinking about public health. Because in this case, I mean, you're right. There's lots of ways that states could respond. They could just sort of take over entire programs. Instead, this seems to be like a case where the state is trying to enable people at the grassroots level to do something that, as you're pointing out, is like has demonstrable like positive health outcomes that are bound up with the way that people are caring for each other too, right? Like experiencing being really loved and cared for in community can sometimes be something that really helps someone care enough about themselves as well, to seek the kind of help that they need, when otherwise they might just be mired in depression, right? Living in grinding poverty and dealing with substance abuse is like really difficult, and also can often be related to, right, a felt sense that you are not cared for in society, right? So I think a lot of what Vandu is doing is also like loving people back to life in really significant ways. And so great that the government is not taking that over and in ways that would potentially like jeopardize that quality of relationship that seems really integral to the program. On the other hand, if we just focus on like whether the government should criminalize or decriminalize, I feel like that's a sort of limited way of thinking about this. And what a relational approach encourages us to do is just sort of step back from the situation, rather than just focusing on what Vandu is doing and what and how the BC government is enabling or thwarting their efforts. Like, let's just take stock of like who all is potentially involved in this particular public health related goal, which is, ensuring that people have adequate care when they're dealing with addiction, dependency, other sorts of things, but are also, while they are still using drugs, are able to do that in a safe and possible way. What about the people in the hospital, for example, who are disturbed enough or are made to feel unsafe or uncomfortable enough that they're reporting that to the police or to the government, right? Don't those people too have a role to play and have some relevant responsibilities with respect to the goal of helping folks in their community, get the help that they need? and find their own way through, addiction-related issues. Why is it just that we just sort of in these conversations tend to ignore, I think, a lot of the time, the fact that people seem to be prioritizing their own feelings of discomfort or safety over like the very real, health and safety concerns of others in their community that are not being adequately addressed. And it's troubling, I think, that, that the BC government would be so responsive to those expressed, feelings of unsafety or discomfort. But unfortunately, it is also a situation where I think a lot of us are still operating within a framework where it's just sort of the government and Bandu that are the relevant actors. So I think, again, I think that pulling back, which is what a relational perspective helps us to do, is to think like whose actions are affecting whom and in what ways are the actions of all sorts of different actors, right, shaping the possibilities for actions of others. I mean, we need to think about how ordinary citizens often make it difficult for governments to do things that would help, in this case, enable a group like Bandu. And certainly there are other relevant actors involved too that we'd also, I think, would be important to bring into the conversation. And by adopting a relational approach, right, maybe that's something that could help those ordinary citizens think a little differently about how they're relating to, right, people who are using drugs in their community and also to the government, right? Like, how do we move away from this sense of kind of like, in entitlement, right, to make, for example, public spaces as conducive as possible to people who are maybe already like in pretty decent health, at least comparatively to people who are, living on the streets, for example. Like, anyway, there just seems like be a massive disconnect there between the attitudes of ordinary citizens and the potential of these sorts of initiatives to really be transformative in a lot of people's lives.
I might just add briefly there. I mean, one of the things I was thinking about was the ways that clinical ethicists are actually really well trained and in some ways like uniquely positioned to be doing this kind of actual relational work. So I'm just thinking that like people who are doing ethics consults and whatever are constantly doing the work of identifying all the agents affected by a case, identifying all the interests, the issues of conflict, the different values at play, the ways that they're intersecting, and like always, I think doing a step back, like what are the bigger goals here and how are we facilitating and building these relationships? And I think in this case, which is has so many different kinds of agents involved, and I'm sure clinicians are involved and have views on what should happen in hospitals and, police departments and all of this, in addition to the clients or patients in hospitals who are complaining and all of it, I think seeing ourselves as clinical ethicists as having the skills and in some ways the unique training to be positioned to think relationally about this stuff and to actually like do some challenging work, as Mike is saying, of actually like raising the ways that agents might need to change and views might need to change and different values might need to be prioritized. But it just seems like the kind of work that clinical ethicists are all the time doing.
Thank you for complimenting my profession. We all thank you. Yeah, I think that you're right, that there is a real sense in which clinical ethics is well positioned to do some of this work. But I also wanted to respond to something that Michael was saying a little bit earlier. Because you were talking about sort of the homeless people and the feelings of fear, and I'm living in Montreal right now, and we certainly have that. We have a lot of people who are unhoused or precariously housed at the moment, and there's also a number of people who are misusing substances. And since we're approaching the fall and it gets cold here, one of the things that always happens is that sort of tends to move into the metro, because many of the metro stations here have really long corridors from the outside leading down to where the trains actually are. And so people start to move that drug use inside. And so, people are reporting feeling unsafe. And there's sort of two things that I think are interesting about this, because, you were talking about the government response of cracking down, and that's an interesting thing, because it's not a response of trying to provide housing, right? Which is another way to prevent people from using drugs in open air sources. And I'm almost 50 now, but when I was a kid, we didn't have homeless people, right? And it was because we thought of housing in a different way. We weren't thinking of housing as being a commodity exactly that could be an investment for international wealthy people and hedge fund groups. And there was, when I was a kid, there was maybe one or two people who were unhoused, and it was sort of like, for them it was a lifestyle choice. But now I would say it's not a lifestyle choice. Instead, it's a public policy choice. And it's also interesting who becomes seen as dangerous, right? Because people who are using drugs in the subway, people respond to that as if they're going to assault you. But then there are other kinds of forces that are also harmful to your health that are not perceived as being dangerous or threatening. I have another question from the audience here. This audience member writes, I wonder if you have any thoughts about the relationship between public health and other kinds of healthcare or social initiatives. Are there enough people feeling responsible for public health? The relationship between health and the state or government seems often to mean that health responses are more acute and reactive than they are preventive. And I think this can be tied into our discussion about Vandu and the crisis of unhoused people that we are experiencing post-pandemic.
I mean, I think certainly, yeah, the question, are there enough people feeling responsible for public health? It does feel to me that people suddenly start caring a lot if their communities are directly, or they or their families or communities or whatever are directly affected. And so, one of the things about the COVID-19 pandemic is that everyone was affected. And so we see a lot of attention to that. And then, of course, very vocal participants on all sides of that. And it does, and that's a great, as this questioner is asking, that's a great example of being reactive rather than preventative, because now that it doesn't, for so many of us, for many of us at least, feel like an immediate crisis, there has been a lot less attention to it. In some other work, I've been interested in thinking about COVID vaccines, and especially the COVID vaccines for kids and how long they took. They just took forever. In trying to even think now in advance of whatever next, virus crisis we have, it just feels like a combination of burnout in response to that crisis and I guess just exhaustion in general, and when responding to so many crises, people just don't seem to have the bandwidth to think very much about, being more preventative or being more sort of like ahead of the curve. And I think this piece of like the exhausting times and how to contend with burnout, and how to contend with like what feels like a constant deluge of needs and demands is a public health issue of its own, right? As we think about responding to constant environmental crises that just sort of seem like, now we're in fire season, now we're in storm season. Like there's always a sort of different kind of climate crisis season, or another kind of health crisis season, or another kind of electoral crisis season, right? There's always some kind of crisis. I don't know exactly what the answer is. It seems like the question of how that for people to be more involved and more sort of proactive and thinking ahead, the requirement would need to be something like that needs to be combined with a sense of meeting one's immediate needs for community, for support, for care, for feeling empowered, And so demands that just sort of like put another thing in front of people to do and to be worried about, to me, seem like they're not working right now because people are very tired. And so thinking instead of like, how can we combine, the invitation to think ahead and be proactive with also an invitation to be building community now and meeting our needs now and feeling cared for and caring for others now. That feels like maybe a kind of invitation that might be more successful rather than just one that insists that we ought to be worrying more ahead of time of the next crisis.
And thinking back to this example, Mayor, I mean, I find it interesting in reading about the way that the BC government was responding to, the complaints about unsafety in hospitals by framing the issue as like as a conflict between public safety and public health, right? That was basically how they were responding and saying that the decision to recriminalize drug use in public spaces would be in the service of ensuring public safety. So I think that's another interesting example where like part of what the Panthers were doing is really illustrative, and we have a lot to learn from it because they started by challenging the state's, or what they took to be the state's understanding of health and like what constitutes health, and we could do similar things when it comes to thinking about public safety as well, right? So like as you were pointing out, the fact that people are unhoused and that the number of people that are unhoused and that then understandably tend to resort to using in public spaces, I mean, all of that strikes me as obviously a safety issue, right? Being unhoused is a public safety and a public health issue. um, but we need to think critically about, I think, like the Panthers were doing, about how state agencies are defining what falls under the aegis of public safety. Is it only things that, for example, law enforcement agencies are capable of dealing with or responding to? That's a pretty limited understanding of what constitutes, a threat to public safety. What about the ways that, as you're pointing out, public policy is undermining public safety? I mean, but then that creates a challenge, right? Because you can't ask, or it's sort of pointless to ask the government to, at least in a lot of cases, it can be, or at least is a exercise in futility to, ask the government to stop doing what it's doing because that's compromising safety. But interesting to think about ways that definitions of public health and public safety deliberately screen out certain sorts of concerns. And they're often the kind of preventative, more preventative, oriented sort of concerns that that Victoria is talking about, right? Like one way of helping to ensure that people are safe and not just responding after the fact by throwing people in jail is to make sure that people have access, to the housing and resources they need to to lead dignified lives.
All right. Thank you very much. We're coming to the end of our time here. So I was wondering if either of you had any last thoughts that you wanted to convey.
I don't think so. I think we both really appreciate the opportunity to think through this again. It's both, I was going to say it's depressing, but it's an opportunity. It's an opportunity to think about how every year it's like we get new examples of public health and precarity, right? And every year it's like the conditions change and the possibilities for agency change, and we have new relationships to work with and build from. And so I think I find it kind of invigorating to be able to return to these questions and think like, where are we now? What's changed, and what can we be doing differently?
Mm-hmm. Yeah, and I'd just like to express gratitude. Thanks to you all for all of the work to put this session together. It was just really a pleasure. It was so nice to see you again, Mayor, and to see you, Victoria. And for folks who don't know in the audience, this is also kind of like a Dalhousie University philosophy bioethics community reunion, which is really beautiful. And I'm really proud to be a part of that, and yeah, honored to be part of National Health Ethics Week.
All right. Well, thank you very much for agreeing to talk to us. as you were saying, Amy, I think it is really interesting to see how these issues of precarity keep coming up, and they seem to be getting worse and not better, I would say, over time. Like even from the time I first saw you present these ideas, the state of precarity seems to be increasing. So one of the things I would hope is that we can find a more robust way of acting together as communities in order to help us build skills to help each other build healthy lives. So thank you very much. And thank you, Victoria and the Canadian Bioethics Society for hosting this discussion. And thanks to our audience members.
I'll just say just a few final words to thank all of you, our panelists, Michael, Amy, and Meredith, very much for this wonderful discussion. It's really great to think, I think, about public health and how different people are involved, how those relationships work, and how that either helps promote the ends that are hoping to be achieved and sometimes gets in the way or interferes with those goals. So thank you so much for this lovely, relaxed conversation about that. We really appreciate all of your thoughts and joining us today. Again, echoing Meredith's comments, happy National Health Ethics Week to the rest of you, and thank you so much to all of you for joining us. So on behalf of the Canadian Bioethics Society, we will wish you a good day and hope to see you at our next Conversations series event. Thank you so much, everyone.